like to welcome Dr. Nathan Rogers. Dr. Rogers is a pediatric cardiologist and heart failure specialist and assistant professor of pediatrics who serves as the medical director of the Advanced Cardiac Therapies team at the University of Minnesota's Masonic Children's Hospital. He earned his medical degree from the University of Guadalajara and completed his internship and residency in pediatrics at the University of Rochester. Dr. Rogers completed his fellowship in pediatric cardiology at the University of Minnesota, went on to complete his advanced training in heart failure, in heart transplant, and pulmonary hypertension at the Texas Children's Hospital. He returned back to the University of Minnesota to practice medicine. He's fluent in Spanish and a native of Texas, Gulf Coast. He lives in Maple Grove with his wife, Melanie, two sons, Gabriel and Christian. With that, welcome, Dr. Rogers.
Hello. Thanks for joining today. Thanks to the Muscular Dystrophy Association for giving me this time to talk a little bit about the heart in the context of Duchenne and Becker muscular dystrophy. And this is tailored a little bit more, talking about it from a pediatric perspective. But just want to mention that I don't have any financial disclosures, but I do proudly discuss off-label uses of medical therapies that are not yet FDA approved in this population. And just wanted to talk a little bit about kind of what we're going to review today. I will briefly summarize kind of what causes Duchenne muscular dystrophy and Becker muscular dystrophy. We'll talk a little bit about the diseases that we see specifically with the heart in this patient population. We'll look at some of the diagnostic tools that we use to assess heart function in Becker's and Duchenne patients. And then we'll review some of the current treatment guidelines and really eyeing some future therapies for this patient population. So starting off with a brief summary of the cause. I know Molly before talked a little bit about the role of skeletal muscle in Becker and Duchenne muscular dystrophy and how that's affected. And with the heart being a muscle as well, it is affected, but in a little bit different manner. So as we know, both Duchenne's and Becker's are kind of on different ends of the spectrum in terms of a problem with the dystrophin protein, which is an integral protein component of muscle cells, not only, as previously mentioned, in skeletal muscle, but elsewhere in the body, and particularly in the heart muscle cells. And this problem with either the forming of the protein or not making enough of it results in progressive muscle weakness and eventual loss of muscle function. And that's particularly important when we're talking about Duchenne and Becker muscular dystrophy patients. So some of the differences that we see between the two groups, in Becker patients, the gene mutation results in a dystrophin protein that's produced, but it's variably abnormal in terms of its content and quantity. And what that does is it results in perhaps a more attenuated form of disease, and that the skeletal muscle may be affected to a lesser degree or have a slower progress, but the heart muscle itself can still be very much affected. Contrast that to patients with Duchenne muscular dystrophy, where the gene mutation is such that the dystrophin protein is either completely absent or it's severely abnormal and severely affects its function. And so these patients typically have a more severe presentation with progressive skeletal muscle weakness throughout the body. And again, because the heart is affected, they do have quite a bit of issues with heart muscle weakness that develop a little bit earlier in life and can be quite profound. And so just to review, the role of dystrophin in the heart is very similar to its role elsewhere in other muscle types in the body. but being cardiac muscle, you have lots of this same type of complex in the muscle cell that Molly had touched base on at the previous presentation. But dystrophin is a very large protein, and you can see it outlined here in the green area, kind of the green dashed line. That overall its function is to help stabilize the cell as it's contracting, and it helps to transmit mechanical forces outward from the cell, and it also has a role in terms of communication between cells and the rest of the body in a process that we term signal transduction. So it's definitely an integral part to ongoing muscle cell function, and when it's not there or it's severely affected in terms of its length and its shape and behavior, you can end up with progression of inflammation within that cell, and the body's response to that inflammation is gradual replacement of the heart muscle cell tissue with fibrous and fatty deposition that ultimately lead to affecting the heart function. And so as far as the next part of it, we'll talk a little bit about the cardiac diseases that we see in Becker and Duchenne patients. And so the main thing that ends up happening is that the changes that happen kind of on a cellular basis, when we take it into account that the heart is one big muscle group there that helps to pump blood to the rest of the body and to the lungs, that when you get this gradual replacement with fibrous and fatty tissue, that causes disease, and that over time it negatively affects how well the heart is able to fill with blood and to pump with blood. And this process we see actually starts quite early on in life, particularly with Duchenne's patients, where it can be evident in about a quarter of patients as early as age 6. But universally, we see it in patients typically by their early teenage years. Because of the absent dystrophin that's there, they have a much earlier presentation of heart muscle disease or cardiomyopathy. In Becker patients, this process can start a little bit slower, but in some patients they may have evidence of this cardiomyopathy really for reasons that we don't fully understand. It may be related to the underlying specific gene mutation and how much the dystrophin is affected. And so some patients may present as early as their teenage years with cardiomyopathy. But for a number of patients, it may not become evident until much later on in life. And kind of the end result with cardiomyopathy is that if the heart is not able to pump the way that it should, kind of the endpoint with impaired cardiac filling and pumping is a clinical syndrome that's defined by an inability of the heart to pump enough blood to the rest of the body in terms of what it needs. And the result of that is backing up of the blood into the other organs and causing disease and a process known as congestive heart failure. And it's important really to talk about this with Duchenne and Becker patients, because it's the one thing that can affect people's health perhaps the most, in that it is now one of the leading causes of death in patients with Becker and muscular dystrophy. And so where previously perhaps cardiologists were maybe not as involved in the care of these patients, over the past 20 years or so, it's become much more important as we've been able to support Becker and Duchenne muscular dystrophy patients in terms of helping their respiratory status and the techniques that we have there, that now because the heart is impaired in terms of its function and the development of congestive heart failure, that a cardiologist is getting involved with the care of these patients. And how the interplay of cardiomyopathy, starting with not really having any outward symptoms or any outward signs of problems with the heart, and then ultimately leading to the outward manifestation of congestive heart failure and causing problems is demonstrated in this illustration here, and it's a complex interaction with the kidneys and the peripheral nervous system that controls things like heart rate and blood pressure, called the autonomic nervous system, particularly the sympathetic portion of this nervous system that typically causes that fight or flight response to boost heart rate, boost blood pressure, and to increase how forcefully the heart muscle contracts. And there are two different kind of yin and yang of regulation of fluid in the body, particularly within the bloodstream, between the kidneys and the heart. So the heart is able to detect when there might be too much fluid there within the chambers, because the heart itself is not able to pump that fluid forward, and the interplay along really hormones, which are able to help communicate between the kidneys and the heart, that something is awry. And that happens along two major systems. One of them is a natriuretic peptide system, which is different hormones that tell the kidneys to pee off more fluid and to lose salt to try to help regulate overall blood volume. And contrasted to the renin-angiotensin-aldosterone system, which really comes from a complex interplay of hormones produced within the kidneys and their effect on different target organs, but really getting at increasing fluid within the bloodstream and increasing blood pressure and holding on to more salt. And ultimately, there is a decompensatory effect when you're entering congestive heart failure, where these hormones cause the heart muscle to try to change its configuration on a cellular basis and remodel in such a way that doesn't really help the heart function overall. And so these are important effects that happen that are potential targets in terms of what we may have in our treatment armamentarium to help prevent between those two systems. Another issue that does happen in patients with Becker and Duchenne muscular dystrophy is an irregular heart rhythm, or what we call arrhythmias. And these are different arrhythmias that can happen that are generated really from any of the four chambers of the heart. You have two upper chambers called atria and two lower chambers called ventricles. The atria receive the blood either from the body or returning from the lungs and is pumped into the two ventricles, which either pump the blood flow out to the lungs or to the body. And there's a complex system of really specialized nervous tissue that's part of these muscle cells that help to rhythmically conduct electrical signals to cause this pumping function to happen. And when there's a replacement of these heart cells in this conduction tissue with fibrofatty deposits, as I mentioned before, you can end up having irregular heart rhythms. And some of the most common ones that we see are going to be ones like atrial flutter and fibrillation, where the upper chambers just kind of quiver and don't do a good job of being able to pump and fill the lower ventricles with blood. And then one particular one called ventricular tachycardia, where the lower pumping chambers will pump very fast and ineffectively enough to support effective blood flow to the rest of the body. And arrhythmias tend to happen most frequently in both patient populations, starting as early as the late teenage years, and can become more frequent in early adulthood. But then again, some patients may never experience anything like this, and or if they do, it may be much later in life in the elderly years, particularly with our Becker muscular dystrophy patients. So the next part is talking about the diagnostic tools that we use as pediatric cardiologists to really examine these children who have been diagnosed with muscular dystrophy, and really are part and parcel of kind of modern guidelines that have been developed in terms of how we screen patients for cardiac disease. And the first one that we start with is the echocardiogram, which is an ultrasound tool that we're able to use to assess for heart function. And you can see here on the screen, it might be a little hard to see with some of the reflection, but the upper picture shows a cross-section of the heart. The left ventricle is kind of that donut-shaped area that you can see is moving, and that represents a normally functioning heart compared to the video here that shows hearts in the same axis. So we're going in a short axis of the heart, and we could see that the kind of donut-shaped portion of the left ventricle there does not squeeze quite as vigorously as the patient that's represented at the top. It's a non-invasive procedure. It's very easy to obtain. It's available at a lot of pediatric institutions. It's fairly quick. Most patients are able to get one done within about 30 minutes. It doesn't require sedation most of the time, particularly in our older patients. But one thing that limits its use is that sometimes the lung fields do get in the way, and sometimes because of contractures and the patient maybe not having quite the strength to move around on the table while we're scanning them, that we do get images that are technically difficult to obtain. So sometimes we just don't get a clear picture, or as clear as a picture as we would like to look at heart function. And that's kind of where the role of cardiac magnetic resonance imaging comes into play, so MRI for short. And this is a study that does not use radiation as some of the other diagnostic tools that we have out there, but it's able to look at heart function and really gets a better picture of what's happening with the heart muscle itself that we're not able to assess on the echocardiogram, really looking at whether or not there's presence of these fibrofatty deposits that are there, the scar tissue within the heart muscle itself. And you could see kind of as on the similar, or on the previous slide that up at the top, we have a picture of, it's just a still frame image of the left ventricle. It's that round shape portion that you see there in black, and blood is there in the center that's white. And that dark ring of tissue from the heart muscle is universally dark. And when there's presence of scar tissue, there's a special type of contrast that we use with this study that we inject called gadolinium that helps to identify areas of scar tissue, and that would appear bright or kind of white within the picture. And that's something that you can see on this lower picture here, where you see not so much of a dark ring there, but kind of patchy areas of white that shows up in there, and that represents scar tissue. And it tends to, in Becker and Duchenne patients, tends to form kind of on the outer side of the ventricle of the main pumping chamber there on the left, and probably happens in that area because of increased stress from the heart beating right there, and that's where you get the most loss of muscle. The MRI is minimally invasive, but as I mentioned before, it does take a contrast medium to help us evaluate the heart muscle better with that gadolinium, and that requires placement of an IV. It does take a little bit more time to obtain. It's about a 1-hour study, and patients must be awake in order to do the maneuvers in terms of breath holding to get the correct images. And sometimes that's a little tough in kids that might not be able to hold their breath long enough, or perhaps they're very anxious in terms of being in an MRI scanner. If any of you have had an MRI, it's very loud. it's dark, you're in a tube for that entire hour. So some children do require general anesthesia with the help of an anesthesiologist to help do the breathing maneuvers to complete the study. And another tool that we use is something that's very simple to obtain, and that's the electrocardiogram. I'm sure most of you have seen kind of pictures of this, of all the wavy lines. This is a snapshot of how the heart's electrical activity behaves, looking at it from 12 different points. Some centers may actually get what's called a 15-lead EKG, and that may be through 15 different points, but most people use this, what we call a 12-lead EKG. So there are 12 different areas that we look at the electrical activity of the heart, and this helps us to assess the function over a several second period of time. It's very easy to obtain and very accessible. Most clinics actually have EKGs that are available, but this helps us to look at number one, how fast the heart is beating, and if there's any presence of arrhythmias that are there. But because the EKG is only really looking at a snapshot in time of a few seconds, it doesn't completely evaluate for the presence of irregular heart rhythms that a patient may be having. So we do what's called an ambulatory EKG. And this picture here over on the right shows you one of the tools that we use here at Masonic Children's Hospital called a Zeo patch. And it's a small sticker that's roughly about 4 to 5 inches in length and about 2 inches across, and fits across the left side of the chest right over where the heart is. And it's something that a patient can wear home, and it captures all of the EKG data for however long the child is wearing it, up to 14 days. So we're able to see over a longer period of time what's happening with the electrical activity of the heart. It's fairly easy to put on. Patients just end up, once the monitor is completed recording, they put it into an envelope and send off to a central processing center, and we get the results within a couple of weeks. And the nice thing about this is I particularly like to use this to look at the average heart rate over time, because as I mentioned before, that fight or flight response portion of the nervous system that has influence on heart rate, we tend to see as patients get older and they develop more heart muscle disease or cardiomyopathy, that their resting heart rate tends to be quite high, to where it's considered abnormally fast. And there is some indication that we may be able to help lower the heart rate and kind of clue us into this is a time where we really should start treating the heart muscle disease with different medications that affect the heart function, slow the heart rate. Some other diagnostic tools that we can use, and again, there's not a whole lot of data to support their use, but things that we can look at are things like a specific enzyme that the heart muscle can produce when it's injured, called troponin. And this is an enzyme that's only present in the heart muscle cells. It's not something that's present in other muscle tissue. And it's released into the blood when the heart is injured. And there is a general trend for particularly Duchenne muscular dystrophy patients to have an elevated troponin level, and it's can help screen for patients who have underlying cardiomyopathy. Another one is called brain natriuretic peptide, or BNP for short. And the data on using this one to look at really the heart's response to increasing amounts of volume because of congestive heart failure and the effect on the heart is not really well delineated. And some studies show that it may not be as helpful as a biomarker to follow, but it's a hormone that's released by the heart when the heart is stretched, because there might be congestion of blood back into the heart because the heart's not pumping blood forward very well, and is there to tell the kidneys to filter out more water and salt kind of on a day-to-day basis, just with regular function, but is at increased levels when you have heart failure. The next portion, we'll talk a little bit about the guidelines for treatment. And really starting with one of the oldest treatments that we have, particularly for our Duchenne patients, and that's the use of corticosteroids. And this has been used for many, many years. There are several different medications out there, including things like deflazacort, prednisone, that have an anti-inflammatory effect on the muscles that help to prolong ambulatory time, so it definitely helps the skeletal muscles. It helps to decrease the progression of scoliosis and can help with respiratory muscle function over time as well. But one of the biggest things that we've seen is that they're cardioprotective because it affects other muscle groups in the body. It does have an effect on heart muscle and significantly delays the onset of cardiomyopathy. And it's thought that that this is due to just an anti-inflammatory effect and a delay of the development of the fibrosis or scar tissue formation within the heart. And there's overall an improvement of survival over time. And we do see this with the paper that was released in the Journal of Pediatrics here, released by Dr. Barber and others here just within the past 10 years. Another group of medications that has been investigated within this population, and particularly looking at Duchenne muscular dystrophy patients, is the use of a group of medications called ACE inhibitors or angiotensin receptor blockers. They're two main group of medications that we use within patients who have congestive heart failure and cardiomyopathy for other reasons. And over the past 15 to 20 years, there's been increased interest in using this, not only to help patients that may have congestive heart failure and already showing outward signs of depressed heart function, but perhaps finding it a role as a prophylactic medication. There's a paucity of data that's out there that says that for sure that these medications help. One of the first studies was a 10-year follow-up of patients that were in France that were given an ACE inhibitor called perindopril, and they found that overall patients that were followed over these 10 years who took that medication compared to patients who were just on placebo actually had better survival in terms of the effect from congestive heart failure and eventual mortality from that. And what these medications do is that, if you remember several slides back, I talked about the interplay of hormones generated by the kidneys that affect the heart and can kind of play a role within the development of congestive heart failure, is that these medications help block that crosstalk between the kidneys and the heart and actually allow the muscle to not remodel in a decompensatory way. Again, there's limited evidence that this delays the onset and potential progression of cardiomyopathy, but an increasing amount of studies that show that it does have some benefit. And my preference is to start this in patients as young as early school age, and generally by the age of 10, the current guidelines that are generally accepted say that you should start an ACE inhibitor whether or not there's any evidence of cardiomyopathy, because of the small data that we have that says that they can slow the progression of it. Another group of medications is called the mineralocorticoid receptor antagonists, which is part and parcel of that renin-angiotensin-aldosterone hormone axis coming from the kidneys, and works in a little bit different pathway to help block some crosstalk that's there. And this includes medications such as aldactone or spironolactone, or Inspra, which is another trade name for a medication called eplerenone. And there is some evidence that this may help slow the progression of cardiomyopathy when we already know that it's present, and ultimately preserve heart function over time. And there's this study from, it was a 2-year study from 2015 to 2017, that looked at the use of eplerenone or Inspra, and showed that it does have some benefit in slowing the progression of heart muscle disease. There are not a whole lot of other studies looking at this in terms of longer-term studies, but one study did come out to show that the similar medication called aldactone or spironolactone works just as well as the pleuronone. And finally, the other group of medications that we commonly use within patients that have congestive heart failure is a group of medications called beta blockers. And these are medications that have a direct effect on the heart to stop that fight or flight response or that sympathetic nervous system effect on the heart that boosts the heart rate, boosts things like blood pressure, and overall can make congestive heart failure worse. And what we know from patients who have congestive heart failure for other reasons is that it's a mainstay of treatment. There's really limited evidence within the Duchenne muscular dystrophy patient population that it's something that's helpful. But in this paper here from the Orphanet Journal of Rare Diseases that came out here within the past 4 years shows that it can, along with the use of an ACE inhibitor such as enalapril, actually delay the onset of dysfunction from cardiomyopathy in these patients. There, unfortunately, is not a whole lot of evidence out there talking specifically about the role of these medications in Becker muscular dystrophy, but I do know that there are some studies that are ongoing to look at whether or not starting a medication prophylactically in that patient population could help slow cardiomyopathy in that group. But unfortunately, stay tuned to that. In summary, just wanted to review that cardiomyopathy is a very important thing to consider in patients with Becker and Duchenne muscular dystrophy, that it does increase in frequency as patients get older, and ultimately this heart muscle disease leads to congestive heart failure and is an important contributor to morbidity and mortality in this patient population. Some of these patients may develop irregular heart rhythms or arrhythmias, and there are different treatments that we have for that. And that with frequent follow-up and the use of the non-invasive tools that I talked about, echocardiograms, cardiac MRI, we can identify heart disease earlier and start a variety of different medications. And the guidelines at this point really recommend that children, as soon as they get diagnosed with both Duchenne and Becker muscular dystrophy, that they be evaluated by a cardiologist, and then particularly in the Duchenne patients, once they are kind of in the pre-adolescent stages, have regular follow-up with a cardiologist with using these screening tools. And certainly with Becker muscular dystrophy patients, I tend to follow them a little bit more closely as they get into their teenage years. With not a whole lot of guidelines for follow-up for that patient population quite yet. Finally, in summary, is that there are a few medications that show promise in terms of slowing the onset of cardiomyopathy and staving off congestive heart failure, and that they do show some improvement in cardiac function over time. And thank you very much for your attention.